Belinda. Thank you, Shannon, for making it easy for me to transition to the next question that I had. For Belinda, with the things that you're doing, right? We are dwelling mostly on the things that you're doing, not the things that we wish you should do, but things that you're doing already. This is something that we learned. We have started to invest your energy on building those face-to-face peer support sessions. What motivated you to start that initiative, and what has been your biggest key learnings over the years or over the months since you started these face-to-face peer support? Because this is something that you're talking about right now.
Thanks for that. Great question. I first got involved in peer support in 2017. So I hadn't actually been a diabetes educator. I mean, I've got a sibling with type 1 diabetes, and that was probably a good 20 years after he was diagnosed. But as a health professional, I walked away from clinic one day and it's just like, this is madness. People aren't engaging. They're not relating to what health professionals are saying. They don't have anywhere to go after 5 p.m. Diabetes doesn't switch off at 5 p.m. on a Friday or a Monday or a Wednesday or any day in between. And it doesn't matter what kind of diabetes, gestational diabetes, type 2, type 1, LADA, MODY, blah, 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 all of them, they never switch off. And I just thought to myself, where do people go when they want support and they can't get onto a health professional? Or where do they go where they have access to health professionals, but the health professionals don't get it? So I went home, I can actually visualize where I was at the time. And it's like I jumped on to social media, Facebook, and had a little bit of a search. And I was very much in the diabetes and pregnancy space at that time. And I found Facebook groups for women with diabetes, mostly type 1 diabetes, not type 2 diabetes. And that's probably another conversation for another day. Why do different diabetes communities from different types of diabetes engage very differently? And actually, James Elliott, he actually posted a brilliant thing just recently alluding to this similar thing. Why does the type 1 diabetes community engage the way that they engage? Why do they have such a voice? And why does the type 2 community not? I think stigma is a big part of that, but it's only my anecdotal observations. I don't have any raw data to support that. But going back to peer support, I joined one Facebook group. It's an Australian-wide group for women who are planning pregnancy, who are pregnant, and even after pregnancy as well. So motherhood with type 1 diabetes. I became very integral to that group. I think probably it helped that I have a lived experience of type 1 diabetes because my brother's had it for so long. So I just could connect a little bit more. Did a lot of work in that group throughout COVID as well. A lot of women couldn't access health professionals at all, went telehealth. There was a lot of fear. I ran some childbirth education classes specifically for women with type 1 diabetes because it's quite different going through an induction versus a spontaneous labour. And I just ran them via a live webinar through Facebook. We started some face-to-face catch-up mums and bubs group, mums and pregnancy groups. We've had some in Brisbane, Sydney, Melbourne, a couple of rural areas in Victoria, Perth, Adelaide. But then I got to a certain point, and this is answering your other question, what have I learned? I think what you need to be really self-aware of as a health professional is not to take over. It's not your community. It's got to be community run by community, and that's very important for Aboriginal and Torres Strait Islander communities as well. But I think you need to know when to step away, and I have stepped away from, I'll still always back the type 1 community, maybe because I do have that lived experience of a sibling with type 1 diabetes. But I think, again, quoting the wonderful advocate that Renza Shabilia is, I think you need to know when to step away and just let community go their way, but still be an ally. So we still need to support community, advocate their needs when they can't, but also recognise that when they know, and let them do it first and foremost, if that makes sense.
Greatly, that really does make sense. Thank you so much, Belinda. That is so great. And usually people back in the days, or this is what people think, to say peer support is something that people with diabetes have to start on their own, but at times they might not have that kind of a push. So thank you so much with your role, also with your career background, but through a peer support group. But there's no judgment whatsoever. We share our experiences, and our approach is to say how we're doing things, because our own diabetes is different and it's unique, and the approach even on how people should be helped or treated, it should be individualized. More power to you, so that it goes on and goes on beyond. And maybe everybody else around the world would believe on the power of peer support, because diabetes can be difficult at times. It's unpredictable.
But I think one of the most important things is just coming back to what Shannon said a little earlier, is that like everything else in diabetes, peer support is also very contextual. Traditionally, we see peer support mostly in the form of Facebook groups, Twitter platforms, online social media type platforms. But in the context of Aboriginal and Torres Strait Islander communities in particular, yarning groups is probably the most relevant form of peer support. My Aboriginal community controlled health organisation is just about to start a yarning group for the community members that have been involved in diabetes research, but they're actually going to start it so that it's for anyone with diabetes. So they provide support to each other because they all live with diabetes. And then through that discussion and that connection, they can help be empowered to inform how research is done within their community. So I think context is also key, because I've heard a lot of, there'll be DDoC symposiums, etc. I've seen this a couple of times at various conferences, and some health professionals will get up to the microphone and they'll go, this is really, really fantastic. How do I connect my clients to peer support? And they sort of miss the point in a way. It's like, that's where you really need to just listen to your clients or the people's needs and actually then empower them with like, well, how do they want to be connected? In Australia, we've got Diabetes Australia, the National Diabetes Services Scheme, Diabetes Victoria in my state. They've all got a web page, all the registered peer support groups. That's all good and well. You can send people off to that, but it might not meet their contextual needs. So you've got to be really careful from that perspective as well.
I don't know what to say. Shannon wanted to say something.
And I think the contextual translating to my clients or my context is really the culturally appropriate practice and approach. So it's about the words, a very buzzy word that we heard a lot of times is about co-design. It is about the people in front of you. They're not numbers. They're a person. So it's about their needs and their sort of family, their surrounding, their needs together. So that's how we're addressing them differently. And I be supporting one of the largest Chinese immigrant peer support group myself here in Australia, and their needs are totally different from other communities, maybe in, back in China or in Australia. So the things they actually like to hear, the topics they like to discuss, it's more about, herbal medicine, Chinese medicine comes up a lot of times. Some of the Chinese exercise like Tai Chi and those, how they actually incorporate into the Western advice about doing exercise, 30 minutes, 45 minutes a day, and how do I incorporate them? They about how do I take my Chinese herbal medicine with diabetes medicine, with my insulin, and how do I inform my doctor about my herbal medication, who actually the Western doctor have no idea about. How should I explain to them? How could I get them to understand it is very important for me to continue taking my medicine, my herbal medicine, not to stop it. Those kind of things are coming from my community, my groups, which is totally different, and they're quite unique as well. So I think as a health professionals, we need to really come back to one of the key learning that you asked me at the beginning, is just to be inclusive and embracing those diversities and working with them. You have empathy. They're coming from different perspectives, different worldviews and different cultures, different languages, and just working with them. If you don't understand, trying to buddy up with someone, actually understand those groups or communities for you to actually gain a deep understanding before you started talking about diabetes.
I think you have already touched naturally on the question that I wanted to ask you, Shannon. So I don't think I should ask you, but maybe I'll just have to run it through you so that you'd know like what I wanted to ask. And maybe if you have an addition to that, you can make it, right? If you're someone who is very passionate about the Australian diabetes health workforce itself, especially the remote areas, the Indigenous and the rural diabetes workforce, what do you wish should be changed?
Thanks, God, you're asking that question. I got a long list and I don't think you have time to accommodate for my list. And I already talk a little bit about what I wish and what I like to be. Definitely the number one is actually enhancing the training and education for health professionals and having specialized training programs and workshops focused on diabetes education and management and tailored to different healthcare professionals, they with different backgrounds, coming from different areas or countries, especially those working in the remote areas or working closely with vulnerable community or groups, because they are the ones really need most of the support. They have the list of resources. So my heart go into those groups, and that's why I like to have some specialized program and workshop actually focus for those vulnerables, health professionals and community as well. Advocate for them for continued professional opportunities, so they have opportunities to upscale themselves as well. I think the second on my list is actually incorporating cultural competence, and I couldn't emphasize more about this. Australia is such a diverse country with different cultures, groups. So integrate the cultural competence and sensitivity training to our program, health education program, that for any of the health professionals, I think it's really vital, because that's help us to actually better understanding their social and cultural determinants of health and affecting on the individual, even though we could be in developing countries, but we still got those vulnerable and most disadvantaged groups in our country. So this will enable our health professionals and our diabetes educators to provide a more effective and culturally appropriate care to our clients. I think I'm only going to mention one more, which also going back to one of my learnings, is promoting multidisciplinary collaborations, fostering a culture of collaboration, working together, and the interdisciplinary teamwork is really important. I think this sort of philosophy needs to be rooted in all the health professionals' head. We need to be working together. We're not a single man, we are a team. So I think encouraging shared learning experience, case discussions involving different health professionals with different backgrounds, like doctors, nurses, dietitians, pharmacists, psychologists, diabetes educators, midwives, nurses, to promoting the holistic care to the people that we're looking after. So I'm going to stop here, even though I got a bucket of list, but because of time, I'm going to stop here for now.
You like this kind of question. Thank you so much for sharing, because this is something that you're dwelling and something that you're already working on. So once it's asked, it just comes out naturally. You don't have to think deeply about it, because it's something that you're doing already. So thank you so much, because you have these wish lists. It's amazing. And probably in the near future, we'll have you back. So thank you so much. Belinda, I have a question for you on the studies that you've been working on. Yes, I know recently you were working on the India study. Now you're involved in the Flash GM study with the Aboriginal and Torres Strait Islander community. What are you hoping to accomplish with this? Or maybe what were the findings with the India study? And now what are you hoping to accomplish with this study? And why is it important just to be part of a study that you're working on?
That's a great question. Both these studies are incredibly different. They're similar, but they're different. So they're both multi-center trials. So we have multiple study sites. They're both nationwide. One is with the type 2 community and one is with the type 1 community. So maybe I'll speak to the India study first. The India study stands for Environmental Determinants of Islet Autoimmunity. So what that study is looking at doing is trying to identify what are the environmental determinants to type 1 diabetes and celiac disease, and how are those conditions actually happening? Are the triggers to type 1 diabetes and celiac disease actually coming from the environment? Traditionally, the narrative has been that if you've got a family member with type 1, you're at a higher risk of type 1 diabetes. Not in my family. I come from a very large family. There's no type 1 diabetes anywhere except for one sibling. And then you will see some families where there's multiple family members with type 1, but we still know that the majority of people with type 1 diabetes do not have a family history. And so with the India study, but also some other studies, the TEDdy study, which is in North America, they've got sites in Sweden, Germany, and Finland. Yep, that's right. And there's some other studies in Europe. They're also finding similar environmental causes or triggers to people developing type 1 antibodies. The India study, it's a 10-year study, so the children come into the study before they're born. It's the only study where there's pregnancy data. The women collect stool samples, urine samples, blood, skin swabs, mouth swabs, saliva samples at each trimester of the pregnancy. And then at birth, the cord blood and the placenta is collected. And then the children are the main participants from age 0 until 10 years of age. And the study visits are 3 monthly for the first 3 years of life. So it's an incredibly intense study. The family's amazing humans to actually put their hand up and to do this study. And then from age 3 to 10, they have 6 monthly studies. There's also a whole lot of questionnaires that look into various elements of childhood health and illness as well. I won't have time to go into everything that the ND said. The poo samples are looking at the microbiome or the gut microbiome. The skin swabs and the mouth swabs, the cheek swabs, the nose swabs, the throat swabs is looking into the virome. So looking into how do viruses, if they do, trigger a person to develop antibodies before they develop type 1 diabetes. The same for the poo samples. The blood that the children provide in the study will actually look at a number of things. So to look at their T cells, we're trying to understand how does a person with diabetes, how does their T cell combination differ to a person without type 1 diabetes? And then even more than that, how does a child who has, or even an adult who has autoantibodies but doesn't actually have clinical type 1 diabetes, how does their T cells differ to a person who's actually progressed to having type 1 diabetes? Because there are, as we know, there are 4 antibodies, autoantibodies that people can have before they develop type 1. You might have 2 antibodies, you might have 3 antibodies, you might have autoantibody. It's not a guarantee that you'll develop type 1 diabetes, but if you have, say, 3 or 4 antibodies, it's about an 80% chance that you will go on to develop type 1. So if we see a child, say 2 children, for example, exactly the same age, same gender, who knows where they are in Australia, they all have a family history in the NDA study, so they've got a mum, a dad, or a sibling with type 1 diabetes. That's the eligibility criteria. But if you take, say, 2 4-year-olds, one who has got no antibodies, and then say one who has got 2 antibodies but hasn't yet developed type 1 diabetes, if you continually monitor them every 3 to 6 months and take blood for them and look at their T cells every 3 to 6 months, the scientists are trying to understand how are those T cells changing for that antibody negative child versus the antibody positive child. And then with that information, they can actually come up with a solution. And at the moment, part of that solution that's being trialed in other studies is the immune therapies. So we know in America, the FDA has approved teplizumab as a treatment for preventing of type 1 diabetes. We currently have it as a trial in Australia, but it hasn't been approved by the TGA in Australia, so we can't use it clinically. And there are a number of other trials using other immune therapies to try and target that T cell mismatch, if you like, to try and repair it, I guess, so that you can actually prolong type 1 diabetes from happening and just either keep them antibody positive without the disease of type 1 diabetes, or actually, fingers crossed, this is everyone's big dream, actually with that immune therapy like abatacept, teplizumab, actually revert those antibodies. Can we actually use those immune therapies to actually bring them back to an antibody negative status? Does that make sense?
Absolutely.
Yeah.
I can see Shannon is nodding. Wow, thank you so much, Belinda. This is an interesting study. And I don't know if you're even allowed to share the preliminary results that you have already with the audience.
So the NDA study is still going. They can't share any findings unless there's something really overwhelmingly positive out of the study. It's still very much going. So the average age of the child is around 6 now. There are a number of children that have started to finish the study this year because they're 10 or older. So there's 1,500 children in the study. So there's probably about 3/4 of those 1,500 that have got another 4 years to go. So we're still... But the amazing thing of those 1,500 families, they have provided so many samples across the decade, basically. The time points all change. So they come into the study and they finish the study at a different point because obviously they all turn 10 at a different age. Every single poo, wee, blood test, skin swab, mouth swab, throat swab, nose swab, placenta, saliva sample, none of them have been thrown out. So they all sit in the freezers in Adelaide, in Australia. And so that has actually made the NDA study the largest biobank in the Southern Hemisphere. So if there are other researchers from other studies in other countries, like the Teddy study, a whole lot of Enodia study, the Daisy study, and a whole lot of other studies in Europe that want to actually do similar things, you can, and it goes back to what Shannon was saying, just the importance of collaborating, because we all just want to get to the end goal of, what is causing type 1 diabetes and how can we stop it from happening. People can actually request or contact NDA to request to use some of those samples. The samples are all de-identified, so they can't be traced back to the person that's donated them. But yeah, the more we co-collaborate, the faster we get the answer. The flash glucose study is completely different. So the flash glucose study is a 6-month randomized controlled trial. That's the study I work on at the moment. We're recruiting 350 Aboriginal and Torres Strait Islander people with type 2 diabetes on insulin or a GLP-1. So that's the Ozempic or the Trulicity weekly weight management medication that people with diabetes can use to normalize their blood sugar levels. It's a randomized trials into using the Abbott Libre 2 sensor, or they'll remain in the usual care group, which is finger pricking group. We don't have much data in the finger pricking group because we know that people don't like finger pricking, but that actually is very valuable data in itself. So we have 6 visits across 6 months, already seeing incredible results. Those of us who are working on the study, for those who are using sensors in the study, the primary outcome is that, do the sensors reduce the HbA1c? Do they prevent diabetes complications? And does it reduce the burden of care? It's a no-brainer. We just need to do the study to get the data to change health policy, which is annoying, but that's just research. We need that.
Right. So thank you so much for sharing that scenario, that experience with us. We know that research is something that is fundamental, that should be funded so that we can come up with new approach. We need to better understand. For us to be able to solve a problem, we need better solutions. Otherwise, it will not be solved and it will remain like that. So it's great that you're working on this. And I hope that you would get proper funding so that you can carry on your studies effectively and come up with better results. Shannon, I know you recently completed your PhD studies in health literacy and diabetes. I would want you to explain to the audience about your research interests. I've never called you a doctor here, but you're a doctor, right? You're Dr. Shannon, but we never called you doctor here. But so please, I know you're a PhD holder, you're a doctor now. Probably sooner, by the time we come back again, you'll be a professor because you're doing this. So if you can explain to the audience.
Oh, thank you for the compliment. My recent PhD is actually focused on health literacy and its application to diabetes, specifically for individuals who actually speak languages other than English, coming from my family, the motivation. My parents actually are the first generation of immigrant in Australia. They're from China, and they don't speak a word of English, but they have to use the healthcare system in Australia. And they have a few unpleasant encounters in here with the healthcare system. And there's a few miscommunication due to the language issues, being ended up with mixed treatment as well. So it was really unpleasant. So that's really touched me and pushed me to pursue my study in diabetes in health literacy. I think I probably need to define what health literacy is before I go in a little bit further. So quickly, definition of health literacy, it's an individual's knowledge, motivation, and competence to access, understand, and apply health information to judge and make decisions about their own health. Determinants of health literacy, it's a lot. It's including individuals' knowledge, education, so their literacy, numeracy skills, their abilities, as well as the complexity of the health information and the healthcare system. So it's got so many different layers, not only to individual, but to the wider sort of environment where they are in, the complexity of the information. That's how health professional comes in to translate, to dumb it down. And the healthcare system, that's an environmental thing that we all live in, surrounding us as well. So it's quite complicated concept. The research actually consists in showing that health literacy disparities exist amongst different cultural and linguistic groups. In Australia, those who speak language other than English at home reporting they are less likely to feel understood and supported by a healthcare professional in the English-speaking settings. And they also have insufficient information to enable them to actively manage their own health. This is the comparison done with those who actually speak English at home. In another study, they're actually showing only 26%, less than 1/3 of immigrants, many non-English speaking countries actually achieve adequate health literacy. So that means more than 2/3 of immigrants don't have adequate health literacy. So that's one of the people, the prevalence that we are dealing with on the top of diabetes. Often we use written health information or diabetes education resources to help our clients to understand diabetes as a way of providing health education. The consideration actually given to those written information for the needs of our culturally and linguistic diverse consumers are very little. So that's where I start. That's the challenging that our community are facing. So I started trying to bridge those, improving the health communication in written information for those who have language barriers, for them to access for health information that effectively conveying the health information in their linguistic need. I contextualize those further into a diabetes education. To address these, I develop a framework that is grounded with the key health literacy principles, and I have done a lot of literature research for what principles may apply to these framework as well. So these frameworks serve as a guide to develop and review the translated patient education resources in diabetes. It takes into account of different linguistic and cultural nuances, aiming to optimize the readability and effectiveness of the translated resources. I developed the framework called them person-centered, culturally appropriate health literacy informed tool, or short for POCA HT. So it's systematic iterative process that I develop with health professionals, with clients and communities. It uses mixed methodologies. In a nutshell, it actually has 7 dimensions. So the first dimension is about translation output, so assessing the quality of the translation. The second dimension is about linguistic comprehensibilities, and it is more mean after you translation how clear whether the intended information from English is maintained in the translated information. And the third is about information believabilities, which is critical for some of the cultural groups. They're looking at who translate, who develop the credibility of that, and it looking at information load, it looking at the cognitive load to a person, especially those with a lower health literacy, in looking at numeracy demand to the person, especially when it comes to carb counting in diabetes, in looking at literacy demand, looking at some of the understanding, labor rating, and etc. In looking at whether the information is actionable, whether after reading those, where a person be able to follow to take some action from there. You're looking at person-centered design. You're looking at what's the cultural preference in terms of color, the font, and the design, the pictures and the images, and etc. It also have additional process of readability screening if the English text is actually available. So in total, there are 7 dimensions and there are 47 items. So it's very comprehensive tool. And I also develop a user guide to facilitate the implementation of the tool, including guidelines and recommendations to users, the eligibility of the material and the scoring instructions and the item descriptions, examples, criteria, and etc. to make it easier for someone to use it. That's in a nutshell of my research.
I think would have needed like a whole day. Thank you so much. Yeah, it's always good like not forgetting where you come from to say what is the need, even if you move to a different country, but then you still remember the people back home that you still need to do like a study that is tailored to them, something that will be helpful. Developing all those guidelines, those frameworks so that people can get their help, recognizing how important it is going into study further, like on the health literacy, because, you know, it's not really being addressed or it's something that was non-existent. But thank you so much for putting that into perspective and having to tackle this. And I believe your contribution goes a long way and it can help people and maybe motivate other people to do the same, to join you in this journey, because you've always been emphasizing on collaboration, inclusiveness, working together with teams so that, because no man is an island, we need to work together. We need to bridge gaps and cover the issues that we're seeing in existence, because we have everything with us to tackle those challenges that we are seeing in excess. So thank you so much. I cannot thank you enough for your brilliance and your contributions. Maybe only a few people know about it. Our access to healthcare does not only include like insulin. We also talk of good access to HCPs even. It's also included. We also talking of there's end stigma, diabetes stigma that is in existence, and there are pledges to end it. I don't know, what would be your last words? Maybe your word of encouragement to the people that will listen to this with all that is happening and all that we need to do.
I may go first. It's very simple for mine. It's actually embracing empathy, inclusiveness, and collaboration. And together, we can bridge the gaps in healthcare disparities and working together to improve diabetes, overall well-being for our communities and for those who actually really need and disadvantaged groups.
Beautifully said, Shannon. I would just go back to what I was referring to earlier, and that is we can all get very bombarded, disappointed and disillusioned with the diabetes has the worst health outcomes for such and such a community. It can be overwhelming. It can be overwhelming for healthcare professionals who are burnt out post the pandemic. It can be overwhelming for diabetes advocates because they're living with diabetes 24/7. It can be overwhelming for everyone. It can even be overwhelming for policymakers, government officials that don't quite know where to start to tackle the conditions. And I think that's where we just have to, I as an individual can't solve the problems of the world. Tino can't solve the problems for the world. Shannon can't solve the problems for the world, but we can make a difference in our own communities. My catchphrase is that we just need to internalize and look at our own communities and increase individual and community capability and capacity.
Well said. This goes a long way. This means a lot. So I like the flow of the conversation itself. And even, like there were so many questions that we wanted to ask, but we cannot touch on everything, right? I don't know if you have any last words. Yes, thank you for the words of encouragement to the audience and everything. I don't know if there are any last words or any shout outs. I don't know, before we close.
Thank you, Tino. I think I want to say a last word and thank you for your invitation. And I really want to actually let you know that on behalf of Life for a Child, we're very passionate and we always have the mission, no child should die from diabetes. So definitely we know the resources, lack of resources in your country and in your area, and you are our priorities, and we are very, very keen to working with you, and our team are very excited to meet you at the conference next week to talking about the next steps. So we are actually coming back to the phrase Belinda said, building up the capacities and capabilities in your local area. So we have exciting, diabetes education program for health professionals. We're wanting to be working with all of you over there to actually be able to increase the capacity and capabilities. We will continue supporting the children, young people living with type 1 in Africa, and supplying the basic needs, essential needs of medicine to them as much as we can. But we are here if you need. Thank you.
And my only thing on that is thank you for everything you do, Tino, because you're just like diabetes, you're an unrelenting diabetes advocate, and the world loves you for it. When you get back from ISPAD, because I know you're going, in the next room I have 2 boxes ready to send your way so that you've got the resources to help your community. So you just say when you're ready and I'll send them on.
I don't know what to say. Thank you so much. With all being said, I would stop the record. Thank you so much, Belinda. Thank you so much, Shannon, for everything, for the kindly support, everything about it. So